Good afternoon, everyone. My name is Jeeyun, and it is a great honor for me to present at the 2021 AIOC KOS Joint Symposium. Today, I will be talking about retinal imaging in neurodegenerative diseases. Before my talk, I will briefly introduce myself. I work as an associate professor at PARAFOVEAL Medical Center, an affiliate hospital of Seoul National University. My research interests include retinal imaging in neurodegenerative diseases, namely Parkinson's disease, as well as ocular genetics of AMD and diabetic retinopathy. If you have any questions about my talk today, please feel free to email me at this address. Parkinson's disease is a neurodegenerative disorder of the CNS and the second most common cause of dementia following Alzheimer's disease. The histopathological hallmark of PD is the death of dopaminergic neurons within the substantia nigra, which results in the typical bradykinesia, rigidity, and tremor seen in these patients. Recently, there has been advanced understanding of the non-motor symptoms such as hyposmia, sleep disruption, depression, and constipation, which initiate prior to the onset of motor symptoms, and heightened hope that if early diagnosis is possible in this prodromal stage, treatments to modulate the disease course may be possible. Non-motor symptoms also include visual symptoms such as impaired color vision and visual hallucinations, with dopaminergic loss within the retina and occipital cortex implicated as the possible causal mechanism. There has been numerous OCT studies trying to understand the pathophysiology underlying the visual symptoms common in Parkinson's disease patients. Most of the initial studies looked at peripapillary RNFL thickness, and as you can see on this forest plot of a meta-analysis study, there is decrease of average RNFL thickness in PD patients. As for studies looking at changes in the macula, most studies have used different OCT machines and analysis protocols with too few patients, and hence have failed to reach a consensus on whether there is or isn't any structural retinal change. Our group has also looked at retinal changes in Parkinson's disease, and this was one of our earliest studies. We focused on visual hallucinations, which is a common symptom in both non-demented and demented PD patients. We looked at the following 5 points in the macula and segmented the retina into single layers and compared the thickness between PD control, PD with visual hallucination, and those with both dementia and hallucination, and found significant RNFL thinning in those with visual hallucination and dementia. Next, we wanted to find out if retinal changes were present in early-stage patients who were drug naive. A few differentiating points for this study were that since we only included early-stage patients who were drug-free, we could gather a homogeneous patient group without any drug effect. We also used the automatic single-layer segmentation software within the Spectralis viewer and used a smaller 3.45 mm ETDRS circle. Microperimetry was used to assess function anatomic correlation, and brain dopamine transporter image was done using a PET MRI to correlate retinal changes with those occurring in the brain. Our analysis showed the presence of retinal thinning, especially in the inner temporal and inferior sectors. And such structural changes correlated with the Hoenya scale, which is a clinical indicator of PD severity. The higher the score, the more severe the degree of neurodegeneration, and as you can see, the significant negative correlation shows that the thinner the retina, the higher the Hoenya scale. Analysis with the dopamine transporter image also showed significant correlation between dopamine uptake decrease and retinal thinning. Hence, this study showed that retinal structural change is present even in the early stages of PD and correlates with clinical severity as well as dopaminergic degeneration within the brain, implying that retinal imaging may be used as a biomarker in Parkinson's disease. Next, we looked at REM sleep behavior disorder in which normal muscle atonia during REM sleep is lost. It may be idiopathic or secondary and often precedes the development of Parkinson's disease, with reported conversion rates between 30 to 65%. We looked at whole retinal thickness and the ganglion cell complex within the same 3.45 mm ETDRS circle, olfactory function, and brain dopamine transporter image. Retinal thinning was evident in the inner and temporal sectors, and when we compared the control RBD and PD groups, we could see a sequential decrease of retinal thickness. Olfactory function, which was decreased in RBD patients, showed significant correlations with GTC thickness, and GTC thickness correlated with dopamine loss in the caudate and putamen. A recent study looked at cell density of dopamine-producing amacrine cells in cadaver eyes and found a profound reduction in PD compared to controls. Looking closely at the perifoveal density in PD eyes, one can see that there is more decrease in the temporal and inferior areas, which coincides with the results of our study. This is a magnified section of the perifovea with an additional overlay of the 3.45 mm ETDRS circle. We also showed the average thickness in color codes to indicate the areas of more profound retinal thickness decrease. PD is a progressive neurodegenerative disease which usually starts with non-motor symptoms. The fact that our studies showed the presence of retinal changes even in RBD, which is thought to be a prodromal stage of PD, shows that retinal imaging may be used as a biomarker in PD, and possibly enable early diagnosis and timely intervention to ultimately modulate the course of the disease. Thank you very much for your attention.